Next presenter, Dr. Paul Michael. Paul is the medical director of the John F. Kennedy Wound Management and Limb Preservation Center at the JFK Medical Center in Boynton Beach, Florida. Paul's going to talk with us today about interventional empathy, feeling for the patient who can't.
Thanks, Lee. Appreciate it. Good afternoon, everybody. That was a great talk, and what a nice segue into what I want to talk to you about. So, a little bit about my story. I started my career in CLI right here at AMP about 5 years ago, and I was sitting in the second row, and I watched every single lecture, and I sat there and I said, wow, all right, this is what I want to do. So at that time, I was practicing cardiac, structural, peripheral, and it was about a mixture of one-third. And I had moved back from New Orleans to South Florida, was making my way, banging around in the healthcare community, and started getting more attracted to peripheral patients, CLI patients. And it was right here at this meeting that I said, there is meaning and purpose in serving these patients through this disease process. And it's a special meeting because most meetings that you go to, you're refreshing, you're learning new concepts. But at a meeting like this, you're not just part of a movement, you're part of something that has meaning and purpose that gives back something that's necessary to humanity, which is improving quality of life in a manner that still needs a lot of recognition because this patient population really has no voice, has no face. So if you understand the language that Medicare speaks, computers speak, administrators speak, you can't extrapolate these patients the way you would search normal disease states. So now start to think, how would you find these patients and how would they find you if you want to treat them? So going from the ground up and starting a CLI practice and eventually becoming a medical director of a wound management limb preservation program at a pretty big community hospital and now starting my own OBL. So I have a hybrid practice in a large community, and access to care issues don't just exist in rural areas. They exist everywhere in this country because of something called critical love ischemia. So if we don't have love for our fellow man, and we're not practicing with love, if we're not practicing with empathy that drives us to do something and to do the right thing, then we're always going to be in a mess where regardless of the disease state or who the patient population is, there will always be disparities in care. The good news is you can make a huge dent in this disease state by caring the right way and doing the right thing. So after I got more involved in CLI, I got significantly involved with the palliative care team at JFK. And I spent a lot of time with them. And I'm on the palliative care board. And spending time with terminally ill patients is no different than spending time with CLI patients. The acute trauma in cancer patients, extend that out. Manifesting with extreme psychosocial traumatic stress is what you have if you live day in, day out in practice with patients manifesting tissue loss, that have amputations, and that don't know if they're going to live, don't know if they're going to be able to walk again. So what is the implications of that? When you start to think that way, then you understand who these people are. And that's the reason why our healthcare system doesn't understand these patients, because they're not looking at them as people. The good news is that we're not responsible for the system that doesn't understand these patients. But we can be responsible for the patients who are not understood by the system by having interventional empathy. So CLI is an incredibly life-altering experience, and it requires the understanding of the whole patient. If we want to understand how the system looks at these patients, they're in trials, they're numbers, they're not people. So modern science, through reductionism, essentially compartmentalizing medicine down into body parts, has basically alienated patients from healthcare. So we need a different way of looking at this. And over the past 30 years, we've been reconnecting to health or wellness systems that are thousands of years old. Essentially, what is that? That's the biopsychosocial way of looking at people and how they have relationships with their environment and their health and their wellness, not just their disease states, because that's how we look at people. So we do know, and this is all proven now in the literature. So because we have data now, we're starting to believe. And I think we understand what the reason for that is. But negative psychological factors independently increase morbidity and mortality. So if you're undergoing repetitive chronic stress with high mortality rates, imagine what the independent negative psychological factors are doing to these patients. So essentially, it's a compassionate approach to integrating CLI therapy to heal the whole patient. That last video you saw, that woman right there, I was moved by her. She knew she was going to die, but you could see by her body language, you could see the look on her face, you could tell by her neurobiology and body posture that she understood that she had a life worth living. And these are the people that we have to be able to bring out, and that's how we get meaning and purpose in this CLI space, by helping people who can't help themselves, and by feeling for people, right, who can't feel their own disease state. And that's a special place to be practicing medicine. And this repairs the relationship between the patients and healthcare by providing whole care in this situation we are in now of health scare. So to serve the art of medicine as it should be served, one must love his fellow man. The lack of that is critical love ischemia. This is CLI as you guys know it, and I want to show it to you how it should be known in a more holistic manner. But revascularization to provide complete wound healing. We're missing the larger wound in these patients, which is the psychosocial wound, and the struggle here is the reality. So reality is experience. Experience is in relationship to other people or others. CLI patients are hidden from the system under modern healthcare practices. So the deeper we study the whole reality of CLI, the better we can understand the meaning of CLI therapy. Instead of focusing on the negatives, which a lot of us get into, myself included, all the time, because it's a tough space to work in, we have to change our mindset to positive thinking, which allows people to understand what the meaning of this disease is, which will compel them to do the right thing. Regardless of that, there's still meaning and purpose in practicing this space. So when that's understood, then the purpose of prevention and treatment is actualized. Essentially, the truth will become evident. Every patient you see is a lesson and much more than the malady from which he suffers. So we need to look at illness as a continuum and just shift your mind to the right there, and that's where the CLI patients are. They start off there and they end there without the opportunity to physically be in what a social norm would consider as health. So what can we work on here? The psychosocial aspect. Just like that lady that you saw, if they know they're going to die, there's still work to do. There's still meaning and purpose in serving these patients. So unfortunately, our system focuses on a treatment paradigm, which is reactive, okay? But society and culture have been telling us for thousands of years, Eastern philosophy, that health is not a reactive program to be taken care of. It's something that starts at childhood, and it should be seen as total wellness, and we're catching back onto this through holistic care. The dimensions of wellness are multifactorial, and I'm getting low on time here, but essentially, Maslow's hierarchy of needs will dictate our better understanding of these patients. The physical loss, the emotional impact, the social challenges, all lead to the loss of self. These people don't feel like themselves. They lose sense of reality, and that's where they break down. We're meeting them talking about arteries, tissue, catheters, balloons, and stents, and we're forgetting that these are people who don't know who they are, who are disconnected from society. So using interpretive phenomenological analysis, essentially questionnaires, very detailed studies, now we can make sense of what they're going through, and now the system can start to understand, but it starts with us listening to the patients. In order to listen to the patient, we have to be able to listen to ourselves in a very special way. So what we use in palliative care is compassionate inquiry. We remove our sense of self. We free ourselves up so that the patient can fully connect with us as they're completely disrupted from their norm. So they're in a constant state of emotional shock and high stress. So essentially the disease severity disables them, and they're in this constant pain cycle, triggering a neurohormonal circuit that just wreaks havoc on their brain. Anxiety, fear, depression, uselessness, hopelessness. I've probably done over 30 suicide phone calls, a lot of in-house calls, a lot of serious situations, repairing these patients individually, their families, and back to function, which may have nothing to do with angioplasty. So they're stuck in the Kubler-Ross change curve between denial, frustration, depression, and back and forth, a lot of times with no sight of a possible therapy or being able to walk again. And this is how we have to look at them. This is how we correct the distancing from the lived experience that they're going through. Understanding their subjective experience requires collaboration, but it requires collaboration on our part to better understand ourselves, to remove the implicit bias that we have the minute we walk in a room. I never look at a chart when I walk in a room with a CLI patient, ever. I sit down in the chair and I say, how are you doing? And I get to know who they are. So we have to be able to engage in a mindful manner to bridge this gap and understand the experience. So diagnosing and treating is what we're used to, but we have to be able to turn toward their suffering, to be able to understand the emotional and the social challenges they're going through. And the tools that we use are refocusing and reclaiming their sense of self. So now they can start to actualize and make decisions, which then get them motivated to want to actually do something. And if you can bring them back to the clinic, if you can develop a relationship, whatever it is you can get them to hook onto, now you're instilling meaning and purpose back into their life, and they're not focusing on being disabled, disfigured, and useless. So reconnecting, coping, adapting, and possibly getting them to thrive again. So empathy and compassion, if you read about this, you can get lost trying to define it. But essentially, empathy is feeling for, compassion is being moved by. So that's where I came up with this term called interventional empathy. There's a cognitive and emotional aspect to empathy. There's the understanding mentally of what they're going through. There's the understanding of their feelings, but that's followed even more so by being compelled to do something, and it can't just be something, it should be the right thing. There's neurobiological evidence now, scientific data of what society has told us for thousands of years, that neuroplasticity can rewire the brain. We can actually improve our sense of empathy. We can adapt to better understand people's emotions, to be able to have better compassion, to be able to understand who this patient is in front of us, which will ultimately lead us to be able to do the right thing. And if we do this on an individual level, then that's what slowly changes the healthcare system, to be able to recognize and acknowledge that these people exist, what they're actually going through, which makes them part of society again. And that's treating the whole patient in a psychobiological manner, not just in a medical manner. So healing the whole patient, not just the hole in the patient, now you're able to actualize a new reality for a CLI patient through a better experiential relationship. What they're going through is their experience. We have to be able to acknowledge that. And acknowledging the other person now brings a completely different continuum into healthcare, where we're getting good at what we're doing, providing a service that society needs. We can actually have a job doing this. We love what we do. And this is what provides for me a sense of purpose and meaning in my life, which started at this meeting, which is known as the Ikigai. So why in CLI? The reality of CLI epidemic, it's complex. It's a disease of suffering. It's a disease of constant change and loss. It's a disease that requires a holistic biopsychosocial approach addressing relationships, which is important. Understanding the whole patient acknowledges the true CLI patient, not just what we read in papers. And these are the real people we meet in clinic, and they're no longer alone. We need compassionate understanding and intervention to do the right thing in these patients. And finding meaning in CLI therapy achieves purpose. And the intervention means preventing harm, improving quality of life and function through a mindful connection, and that's the why to be in CLI. Thank you so much.